свързани с менето на слуха. Искам да ви благодаря, че се отзовахте на нашата покана и да дам думата на професор Дацер. Вие всички го познавате, ние многократно сме го представили и ще му дам думата за четвъртата лекция. Вие Стефан, вие професор Дацер. Thank you that we come in our university to give a lecture, to give academic lecture, and yours is for lecture.
Okay. Thank you very much, Peter, for the kind introduction. Dear colleagues, ladies and gentlemen, it's a great pleasure for me to be here again in person after two online presentations in December and in September. And I'm more than happy to give the last out of 4 presentations with the head topic, hearing quality as life quality. We started last year with the first lecture talking about how hearing works in mammalians and what hearing is about for human beings, in particular in the social surroundings and in the social community. In the second presentation, I presented the causes of hearing loss, and we discussed the conservative options for treating hearing reconstruction. Then, right before Christmas, we talked about surgical options of hearing rehabilitation, and I presented you surgical strategies like tympanoplasty, stapes surgery, etc. And the topic of the last presentation today is indications and surgery of implantable hearing devices. So, as many of you probably know from the last talks, I'm from the city of Bochum, which is in the midwestern part of Germany, about 400 kilometers from Berlin. And this is an air picture from our university, the Ruhr University in Bochum. And I myself, I'm the chair of the Department of Otorhinolaryngology at the Ruhr University. And these are some of my professional data. Most important for today, I'm a proud honorary member of the Bulgarian Otolaryngological Society since several years. And therefore, I'm more than happy to be here and give lectures at Trachea University. These are my disclosures that should not interfere with the contents of my talk. And today I will speak about the different kinds of implantable hearing devices that are indicated if conventional hearing aids are not efficient anymore. So these are not therapies of first choice. The first choice usually is the fitting of a conventional hearing aid. So we will talk about bone conduction implants, active metal ear implants, cochlear implants, and a little bit about brainstem implants too. Let's first look at the auditory pathway to identify the different locations where implantable hearing devices may be adapted to. Diseases of the outer ear canal, the tympanic membrane, and the ossicular chain, incus, malleus, and stapes usually go along with conductive hearing loss. And to treat these patients with implantable devices, we have available the active bone conduction hearing implants, which are usually coupled to the bone of the skull here in this area. I will show you how it works later on. And we also have the active middle ear implants, which are usually coupled to the ossicles. And the interesting thing is that there are different places available where the actor can be placed to. Diseases of the inner ear, of the cochlea, usually go along with a sensory hearing loss. And these patients can be, in selected cases, treated with a cochlear implant. If the auditory nerve itself is affected by diseases like vestibular schwannoma or certain infections, genetic diseases, we have the chance to give the patients a brainstem implant. This is usually provided by the neurosurgeons in cooperation with ENT, and that will not be the main topic today. Most people that suffer from a sensory hearing loss most people that suffer from a hearing loss have a sensory hearing loss. And this is a huge number. In Germany, it's about 20% of the population. So about 15 million people that more or less have a hearing loss associated to the inner ear, to the cochlear hair cells, as discussed earlier. And the first choice is to treat these patients with hearing aids. Hearing aids are well known, and we have those who are behind the ear, and they are connected with a thin electrical wire to the external auditory canal with this little umbrella here. And we also have hearing aids that can be placed inside the external auditory canal. And in Germany, at least, patients are provided with hearing aids by acoustic persons. And the indication is done by an otolaryngologist, by a physician, and the adaptation of these devices is done by acoustics. So the indication for hearing aids is relatively strict in Germany. So we have clear and standardized guidelines, which is hearing loss of 30 dB or more in the frequencies between 500 and 3000 Hertz. These are the main speech frequencies. And if we look at the speech audiogram, it's speech discrimination, monosyllabic words at 65 dB of 80% or less. And 65 dB is about the loudness we are talking to each other. So my loudness would be about 65 dB now. So this is where we measure the monosyllabic word understanding, and if the result is 80% or less, the indication for a hearing aid is given, so to say. We then have to hand out a prescription form to the patient where the thresholds and the speech discrimination test is placed and documented. And we also put in the diagnose and the site. So is it one side? Is it both sides? So this is a bilateral indication for hearing aid fitting. And with this form, they go to the acoustic person who does the fitting of the hearing aids. And if the patient is happy, he comes back to the ENT doctor. He looks whether the hearing aid is fitted well. In most cases, this is probably a reasonable way to treat persons. But if they are not happy for one or the other reason, recurrent infections of the outer ear, malformations, situation after many ear surgeries, and other reasons, they may be candidates for different implantable hearing devices. And this is the topic of today. So we have bone conduction implants. We have the mentioned active middle ear implants. And we will speak about cochlear implantation. Again, a view to the auditory pathway and the different locations where the auditory implants may be adapted. So the bone conduction implants are fixed at the bone right behind the ear, in this area. In the outer ear canal, usually we have the conventional hearing aids, either in ear or behind the ear devices. Inside the tympanic cavity, the active middle ear implants are located with some adaptation to the ossicular chain. Cochlear implants will be surgically will be surgically inserted into the cochlea. So this is the yellow area of the inner ear. And finally, the rare cases where auditory brainstem implants are necessary. These are the acoustic areas on the brainstem, and surgery is done by the neurosurgeon in cooperation with us and the audiologists. So this is how the different devices function. A hearing aid consists of a microphone, an amplifier, a processor, a micro loudspeaker, and this system somehow gives processed sounds to the external auditory canal, to the tympanic membrane, ossicular chain, and then the natural way to the inner ear. If we look to the bone conduction implants, again, we have a microphone, amplifier, processor, but the coupling, the adaptation is directly to the bone, and I will show you how that works surgically. Active middle ear implants have the same building, but they are adapted to the incus, the stapes, even possible to the round window area. I will show you that. And cochlear implants are a little bit more complicated than these more simple devices. They have a speech processor, and the information is then electrically transferred into the cochlea. So we insert the electrode through the round window into the scala tympani, and I will also speak about that later. So the first group of implants are the bone conduction implants, and our main working horses are the Ossia system and the bone bridge system. So they are partially implantable hearing devices with an external audio processor, this and this. And the implanted part are these both parts, and I will show you some surgical slices. Not too much blood, you don't have to be afraid. So this is the bone bridge system by the Med-El company. The implanted part goes right under the skin on the bone, and to take up the activator, so this is the part that vibrates, electrically driven, we are going to drill a cavity into the bone and choose a size that the activator exactly fits. And then we fix it with two self-winding screws. So it's a little bit like handcraft work to fix this implant. And then we close the skin, wait for the wound healing. And after a couple of weeks, the audiologist can then go and program the external audio processor. So that works pretty well as a surgery, which takes about 30 to 45 minutes. Does not mean much harm to the patient, and is quite effective. This is the second device we are using, the Ossia system, and it's basically the same. We have an implanted part right under the skin, which is fixed to the bone via a screw. And then the system is fixed on this screw and the skin is closed again. So the indication for these devices is again the audiogram, and the sensory hearing, the inner ear potential should not be worse than 30 to 40 dB. Bone conduction is not a problem that can be directly overcome with these devices. So if a hearing aid is not possible for the patient, this is, at least in Germany, important for the health insurance companies, because these devices are more expensive than conventional hearing aids. So if there is a medical reason they cannot wear conventional hearing aids, then these devices may be an option. Talking about active middle ear implants, on the first view, they look similar, but they are coupled at a different place along the auditory pathway. So on the market, we have two systems right now, the Vibrant Sound Bridge system by Med-El, and the Esteem implantable hearing device. This is a totally implantable system, so also the audio processor is implanted into the patient's head, so to say. And the interesting thing is that the tympanic membrane serves as a microphone. So the sound take-up goes over the tympanic membrane. Here we have the sensor system, which gives the information to the processor. The processor can be programmed according to the patient's hearing situation. And then the electrical situation is given to the driver, to the actor, which is coupled to the stay-piece. The problem in this system is that we have to interrupt the ossicular chain, because the server is coupled here and the driver is coupled to the stay-piece. The incus needs to be removed. So if the system is off, the patient has a conduction hearing block of about 60 dB. So he's only able to hear when the system is on. The SoundBridge system, which is very popular in Germany and I think in Europe too, and is in our country basically the only active middle ear implant that is applied, works with this little floating mass transducer. This is an electromagnetic driving system which moves forward and backward. And with this little titanium clip, it can be fixed to the ossicular chain, and then the vibrations go onto the chain and will be transferred via the stay-piece footplate to the inner ear, as it is done in the normal hearing patients. So what are the expectations to an active middle ear implant? What we want to do for our patients is a hearing rehabilitation in sensory neural hearing loss. So if they have only inner ear hearing loss, or in combined hearing loss, in some patients also only with a conductive hearing loss. So we want to treat the different kinds of hearing losses with this system. Preservation of middle ear anatomy is very important in my view. That's why we prefer the SoundBridge system. And we also estimate the small size of the implant and the activator, which can be coupled to different areas inside the middle ear, depending what is available, for instance, after middle ear surgery in these patients. Oops. That was too quick. So that is how it works. External audio processor takes up the sound information, transfers it to the implant. The implant gives it to the activator. The activator vibrates according to his fitting situation. And then, as you see here, information is given to the inner ear and transferred via the auditory nerve to the central auditory areas. So this is the place where the audio processor sits. And if you have a longer hair, you can cover it. And it's not very much annoying or discriminating. Most people can hide it under the hair. And what we really estimate in the SoundBridge system is the option to place it to different locations. So the little activator can be coupled with a certain coupling system to the incus, short process of the incus. It can be coupled to the long process of the incus, if necessary. And if the ossicular chain is not present, in all its parts, it can be also coupled to the head of the stay-piece with the stay-piece coupler, and it can even be adapted to the round window niche with this little conic round window coupler. So we can basically provide a direct drive of the inner ear by this system placing it into the round window area. So many options for the surgeon and also for the patient. And that's why we have, during the last year, many different indications for the SoundBridge system. So this is a case presentation of a 6-year-old boy. he has a large malformation of the left ear, and this goes along with an atresia and also with a malformation of the middle ear parts. The inner ear, the cochlea, is interesting enough, is completely intact. And this is in most cases of malformations that the inner ear works well. So we have to think about how the air-bone gap, the maximum conductive hearing loss of 50 to 60 dB, can be fixed. One option is to give these kids usually a conductive hearing loss, which presses on the bone, and they can hear over bone conduction. This is usually a little inconvenient, sometimes painful, and therefore these patients may be provided with implantable hearing systems. And in this case, we gave the young boy a sound bridge system. So from the temporal bone CT scan, you see it is a nice aerated mastoid. The tympanic cavity looks good. The cochlea looks nice. This is the area of the round window, which can be seen nicely. The other side, the right side, is completely normal. But what you realize is that there is no external ear canal. Look to this side. Should be filled with air, so black in the CT scan. This is how the external ear canal looks. This is not present here. And this is the reason for the hearing loss in combination with the malformation of the ossicles. So in older times, we tried to reopen or to construct an external ear canal, which was difficult and which sometimes took more than one surgery for these patients. But since we have the implantable hearing devices, we can rehabilitate these patients with one surgery, as I can show you now. So we open the mastoid, identify the ossicular chain, test the mobility of the chain, and if that is given, we then are able to adapt this little floating mass transducer, for instance, to the short process of the incus. This is the U-coupler here, to the body of the incus, or to the other parts I showed you already. And these are the hearing results of a series of 15 patients with atretic malformations of the ear. And as you see, the air-bone gap could be completely overcome by these devices. And this is an easy way to rehabilitate them with low risk and a high chance of good hearing success for these patients. The next group of implants are the cochlear implants. And these are at the moment also partially implantable systems. So we have the external speech processor, which may be worn behind the ear, or there are also processors that can be just clipped. They are held by magnetic forces here right on the skin. So this is the external part. And then the information goes to the internal device, which transfers it via the electrodes into the cochlea. And as you can see here, the surgical procedure includes the presentation of the round window, opening of the round window, and then we surgically insert the electrode into the scala tympani, which is one of the three canals inside the cochlea: scala tympani, scala media. You remember my first lecture, here is the organ of Corti and the hair cells, scala vestibuli. And we can nicely place the electrode through the round window into the scala tympani. And then through these little electrodes here, the ends of, or the endings of the auditory nerve, the spiral ganglion cells and the spiral ganglion dendrites will be stimulated electrically, and the information then goes through the nerve towards the central auditory areas. This is how it looks after the surgery, when the hair mostly covers this system. like the others too. And the cochlear implant supply had a lot of changes during the last years in Germany, we have to say. And we have a medical guideline and a CE white paper available since a couple of years. And the supply process is well defined. So we differentiate between a preoperative area where the diagnostic evaluation is done and the indication is placed. Second step is the operation, so the surgical part of the cochlear implantation. After wound healing, we then start a basic rehabilitation time, which is basically fitting the processor to the patient's need. Takes about 4 to 6 weeks usually. And then the following therapy includes speech and hearing therapy for the patients. And this depends whether we have small children or adult person. I will talk about that, about the different challenges in rehabilitation after cochlear implant provision. And if the therapy is finished, we then have a lifelong aftercare, which takes place once per year. So what you learn from this prescription is that a cochlear implant patient basically has a lifelong relationship to the clinic where the implantation is performed. And all this also includes that we put the patients in a national CI register in Germany. So we give the information of diagnostic, surgery, rehabilitation, and performance after years. We give all this data into a register to get information how the whole population of CI candidates works. And we can then hopefully in a few years give a good overview about the results in Germany. So these are the different implants available from the different companies, Cochlear, Advanced Bionics, Med-El, Oticon. And we usually tell the patient these are all high precision and high technical devices. And the difference is a little bit like driving an Audi, a Mercedes, or BMW, for instance. Sometimes there is a medical reason to choose one or the other implant, but usually you can go for these implants that are available, and the patient can also decide what he wants to have. So the indication is clearly regulated after the medical device and the CE White Book. And a rule of thumb is if a patient with an adequate, so with an optimal hearing aid supply is not able anymore to use the telephone, then we should start to think about a cochlear implant. And what we do is several tests and investigations. And the audiological test usually is the speech discrimination test, you know already from the hearing aid prescription, which is done at 65 dB, so the loudness of normal speaking. And we do this test with an optimal hearing aid fitting. And if the patient has a discrimination of monosyllabic words with less of 60%, then he is a candidate for cochlear implant. So in difference to earlier times where the patient had to be deaf, today there may be even a remaining hearing situation in the patient and he is still a cochlear implant candidate. And this is because we are today able to preserve remnant hearing situation in patients. And I will speak about that later a little bit. So this is probably an important take-home message. Cochlear implants are not only for deaf patients, but also for those who do not benefit from other hearing implants, but still have a remaining hearing situation. We also have to look to the anatomical situation of the patient. And I always like to show this nice scanning electron pictures by the group of Helge Rusk Andersen, which shows that every cochlea from every patient looks different. So we have large people with small cochlea or the other way around, and you see that the shape is different in all these different patients. So the individuality is a little bit like a fingerprint. And we have to keep this in mind, for instance, when we choose the electrode. You know, today we are able to choose an electrode according to the anatomy of the patient and to the hearing situation of the patient. So it's not only placing the implant into the inner ear, and that's it. That was like 15 to 20 years ago. Today, we try to individualize the patient situation when we do the cochlear implantation. And therefore, we do additional radiological investigation, for instance, the MRI scanning. And it's important to check together with the neuroradiologist the situation of the cochlea. This is the cochlea on the left side. On the right side, this is vestibular system. You nicely see the horizontal vestibular canal, and also the internal auditory canal, which connects the cochlea and the vestibular system with the brainstem. And we look for the integrity of the cochlea. We check whether the cochlea is filled with fluid, and we check whether the hearing nerve, the auditory nerve, is present, has a normal shape and thickness, because in malformation you may have a nerve, but it's very thin. And then you have to question whether this nerve can be stimulated by a cochlear implant. And we also test whether the nerve has contact to the cochlea. In some cases of malformation, this is also the case, that there is no contact between cochlea and nerve. And of course, cochlear implants cannot work there. So these are the questions you are answering. You also check whether there is a vestibular schwannoma, for instance, which also may be the reason for hearing loss in this patient. So MRI is mandatory prior to cochlear implantation, and also the CT of the temporal bone, the computer tomography, is important and necessary. And this basically gives information about the bone situation of the temporal bone. So the mastoid, which should be aerated and plain, as shown in this situation, external canal, region of the tympanic membrane, ossicles, and again, the cochlea with the basal turn. And here you can make out the round window niche. Here is this little bony overhanging, which needs to be removed during surgery to expose the round window area to place the electrode. So all this is done prior to surgery and discussed in an interdisciplinary team, similar to cancer teams. You know, probably in your departments, the cancer teams. And the cochlear implant team also consists of different profession parts. We need the ENT doctors, of course, the surgeons. We need an audiologist, logopedic persons. If we talk about children, pediatrics and neuropediatric persons. So it's a relatively big team that sits together and discusses the patients. So we have to differentiate between children and adult persons, and children are in particular of interest if we have a congenital prelingual deafness. So that means these children are born with deaf ears, or one deaf ear. So they never had a chance to hear during pregnancy. In my first lecture, I told you that the babies usually start to hear during the last third of the pregnancy, and this is very important also for speech development later on. So these children don't have the chance. And they are diagnosed usually by newborn hearing screening, which is present in Germany for many years and also present in Bulgaria, as I learned. And if these children are identified, they need an early hearing aid fitting by persons who know how to do this with newborn children. So these are pet audiologists and audiologic persons who do this. And they can also check whether the development of speech is good enough or not. And if this is not sufficient, the children should be implanted with a cochlear implant in between the first year of life. Then they have a good chance to develop speech and to develop hearing later on. And if the implantation is done later, after the second year of life, then the prognosis is much worse. If necessary, we try to do a bilateral implantation in these kids in one surgery. So this is about a surgery of 3 hours if you do left side and right side, 1.5 hours on each side. And this has to be planned with the anesthesiologists. It's not easy to have a small kid with about 1 liter of blood. And if you lose 100 milliliter, this is 10% of the whole blood volume. So you have to be very careful to treat these patients, and you need the interdisciplinary team. It's a little easier to treat older children and young adults and older adults with a postlingual deafness. So the ear and the brain had learned how to hear and how to speak and how sounds sound, so to say. So there we don't have the time pressure as in these very young children. The indication I told you already, these speech integrity tests. And what we usually do is we implant the worst side first. So these patients may have an implant on one side, cochlear implant on one side, and a hearing aid on the other side. We are speaking about a bimodal situation. And this, interestingly enough, works very well. So the brain is able to fuse electrical and audiological signals to one perception. And this works pretty well after a certain time of training and when they are accustomed to it. We have one exception where we also have time pressure, and this is deafness after meningitis or trauma. The reason, because the time is limited, is that the cochlea can be ossified, can be occluded by tissue, by bone, and this may happen pretty fast. So sometimes in between 4 to 6 weeks. So we have to really follow these patients and talk to the neurologists because they usually treat the meningitis or the neurosurgeons. And then we have to follow them precisely and give him a cochlear implant pretty early before the cochlea is closed and blocked for a cochlear implant. What is also important to know, there's no upper age limit. So we have patients that are more than 80 years and they still have a good benefit from cochlear implantation. And life expectation gets longer and longer and longer. And in particular, older people, we have talked about this earlier, are very dependent on their hearing situation to get social reintegration. We don't have a higher risk in older people if we do precise diagnostics. And if necessary, if the total anesthesia is too dangerous for them, we can even implant them in local anesthesia. A few words about the surgical situation. This is how the setting in the operation room looks like. The patient, the instrumentation table is always oriented in the same way. So there should be, let's say, a blind understanding between surgeon and the nurse who does the instrumentation. This is important. Here you see the surgeon's place, the nurse's place, the microscope, and anesthesia is on the other side usually to cooperate but not to be in the way. At the end, I would like to present you an interesting case where not only cochlear implantation is the challenge, And this is a 52-year-old man with a progressive hearing loss of the left ear over many years. When he came to us, he was deaf already on the left ear with a normal hearing on the right ear. So we did the diagnostics I presented to you already. So this is the MRI with gadolinium. And what we saw here was this neoplasia in the horizontal vestibular canal. And you can also see a mass here in the CT scan in the horizontal canal. And as you know, that vestibular system and hearing system is one anatomical and physiological compartment. This is obviously also the reason that the patient got deaf over time. So here we found an intravestibular schwannoma, which is responsible for the deafness. And we have the two challenges to remove the tumor and to rehabilitate the patient for hearing. So what did we do? This is an intraoperative picture. Left ear, this is an opened mastoid. So you remember the mastoid from the CT scan already. The cells are drilled out and we exposed the important landmarks, which is the incus, the horizontal canal, the posterior canal with the blue line here already, the superior semicircular canal. And here you can even make out the course of the facial nerve through the mastoid, this reddish rose shining through the bone. This is the facial nerve. And this is the posterior tympanotomy, where we go for cochlear implantation and also for some implantable hearing devices. So what we did was opening the horizontal canal. This is, can you see here in this higher magnification, remove the tumor. These are parts of the tumor. Obliterate this area, and then go through the posterior tympanotomy to the round window. And in this case, we have to check whether the auditory nerve is still can still be stimulated. And this we do with a test electrode. We have these little 1, 2, 3 test electrodes and the electrode carrier. And this is inserted into the scala tympani. And we can then intraoperatively measure, it's an electrical ABR, auditory brainstem results. And we can test whether we can stimulate the nerve. And if that is possible, the patient is ready for cochlear implantation. And here we see wave 5 in the ABR measurement. So this is a good sign. And then we can go, we can expose the round window as shown here. We can remove the test electrode and place the real electrode through round window into the scala tympani. And then we do an intraoperative or post-operative testing, depends on the situation. And here in the CT scan, we can prove that the cochlear implant sits correctly in the cochlea. And after a few weeks, after fitting of the patient, we do the measurements. And as you can see here, this patient had benefit at 65 dB. Again, language loudness. So he had success of 70% monosyllabic words, which is a good result. And you can even improve this to 85 when you go to 80 dB. So this is a nice result after cochlear implantation, after the planning. So what are the future aspects of cochlear implantation? You always think everything is known. We can treat the patient, everybody is happy, but there are still things for the future to expect. Fully implantable devices are available already, not on the market, but there are prototypes already. And a few patients are implanted already with a fully implanted cochlear implant. So this will come during the next 1 or 2 years. A couple of years ago, we started already to do electrophysiological measurements during the implantation. And the reason for that is that we want to be very atraumatic to preserve the structures inside the cochleus and to preserve residual hearing. Drug delivery is a topic at the moment, so we take part in a clinical study where the cochlear implant electrode is covered with steroids in this case, and we will see whether that also improves residual hearing preservation. Robotic is discussed and applied in cochlear implantation. I will show you a picture in the next and in the last slide. And optogenetics in cochlear implantation is a very interesting topic in combination with gene therapy, because the spiral ganglion neurons need to be susceptible to light, and that needs gene therapy. So this will probably also go into the clinical application soon. So the last two slides show robotic application during the insertion of the cochlear electrode. This is the robotic arm. This is a little forceps you see on this picture here, which holds the electrode. The electrode will be fixed into this forceps. And after directing it in front of the round window and open the round window niche, the computer, the robot, proceeds the electrode with a feed rate of 0.1 millimeter per second. This is pretty low. You can almost see it, that it goes in. And it moves over like 4 or 5 minutes into the scala tympani. And the surgeon has 2 hands to guide the electrode. And you steer the stop and go with your foot. So if the electrophysiological measurement says, okay, there's danger for the remaining hearing, for the residual hearing, you stop, and you can even retract it and give the cochlea a chance to recover, and then you continue. So we are doing this since January of this year. So we have maybe 11 or 12 patients treated with this robotic arm. And our measurement of the impedances shows a benefit. So the impedances are lower. And the residual hearing, the preservation of the residual hearing seems to be better. These are very preliminary results. But all these new aspects, these assistant systems in cochlear implantation, aim for preservation of residual hearing. All right, so I hope in these 4 lectures I could show you how hearing works in mammalians, how important hearing is for human interaction. I hope I could show you some options of therapy, conservative treatment, surgical treatment. And the aim of all these trials is to support the ability of disabled patients for open communication in social surroundings, to improve autonomy in everyday life, in particular in older patients, and to support self-confidence of these patients. So listening to music, to conversation, to the sounds of nature and environment, and many other things should remind us that these perceptions are all provided by the hearing system, and that this hearing system is an important sense of life. And I hope that my lectures will remind you during your further medical career, always on the headline of all these talks, that hearing quality is life quality. Thank you very much for your intention and that you listen to me. And if you have questions, I'm ready to discuss. Thank you very much.
Dear colleagues, we have a great thank you for Professor Dazert these wonderful lectures, not only today, but the 4 lectures. And when we have a question, please ask. Yeah.
Everything was quite clear, obviously.
Really, the lectures was very didactic, very clear, and very helpful. I think many of my colleagues say that this lecture is improved the knowledge of the hearing and continuing to.
Can please you in new generation of cochlear implants, the fully integrated implants, don't we lose a little bit of the versatility of the external auditory processor? Because in older patients, in older generations of implants, we change with the newer advancements in the field, and the patients have better hearing, better quality. Don't we lose that with fully implantable devices?
I absolutely agree with your opinion. I am a friend of the partially implantable system just for that reason. Every 5 years about we have new processors, new technology, new computer system, chip systems, and you can easily, provide the patient with the best processor available. Some of these advantages obviously can be also programmed through the skin. Like the pacemakers, they are also programmed through the skin. The limiting system in these completely implantable systems, in my opinion, is the battery. So that obviously lasts for 8 to 10 years. These are the calculations. And then at least the battery has to be exchanged. And that can be done via a little skin incision. So it shouldn't be that bad. But I absolutely agree with you. I like the option that we can change the processor according to the technical development. But people ask for totally implantable systems. So obviously the market is there.
Other questions? Any comments? Yeah.
Okay.